After Amish's very interesting talk, which is the most complicated part in the heart, mitral valve, the whole eco industry has been developed for mitral valve. Aortic valve is nothing in that. So it is same. It is same, but why it is important, we will just go through that. But the concept is to find the presence of abnormality, severity, as he has said, etiology, and associated lesions and effects. So in short, what we are going to do is 2D imaging. So predominantly the structural examination, which is gaining more and more interest nowadays. Then the Doppler, either it's a color Doppler or a spectral Doppler, to come to know about flow or haemodynamics, which is a dynamic examination, and to assess what is happening with the heart. So normal aortic valve, it is a classic thing. Everybody should know that, because everything Mercedes-Benz and all those signs, that is, if you see this, then you will realize, oh, that is a Mercedes-Benz sign. Because every time people may not be aware what is Mercedes-Benz, which is natural. I don't blame that. It is not that everybody should know about Mercedes-Benz. Aurangabad people know it because they bought 100 or 60 Mercedes-Benz at one time, but I don't know how many remained in Aurangabad afterwards, because I think the company ran away because of the roads. So that's the Mercedes-Benz sign, which that is because of the three cusps. So three commissures, and there are three sinuses which are supported by the fibrous annulus, and it shares all that with the mitral valve. So the usual area is 3 to 4 centimeters square, and node of Arantius is the central part of it, which is the structure you can easily appreciate on echo as well, and that's why you should know about it. So this is how it is. So there is a inter-leaflet triangle, which is something important, which obviously from a surgical perspective all this is important, and that's why you should know how exactly is the anatomy of the aortic valve. And the whole aortic root, what they say is, this is the thing which is aortic root. Because sometimes in the cardiology reports you will see aortic root sizes, they are mentioned, but the surgery is actually interested in the aortic annulus sizes. So where we are going to measure that we will see. And so that's a native stent which is supported by 3 aortic cusps. It's a functional aortic annulus, and that's why everybody looks at it as very important. Then there is the ventricular aortic junction, and that is the actual aortic annulus which we measure. And then the sinus of Valsalva distance that Deepak has showed you, and the sinotubular junction STJ. And why that is important? Because the aortic annulus and the STJ has a relation. So they should not go 1 to 1.5. The ratio should be always maintained like that. And that's how the whole system works, as a coherent unit. If that distance changes, then there are the chances of aortic regurgitation. And that's why when they are doing the repair, the surgeon will meticulously measure it and see that whether either way the aortic valve leaflet repairs or the annuloplasty thing. That's how they are going to compare it. So what are the classic things views for aortic valve? It's a mid-esophageal aortic valve short axis, which is usually at around 30 degrees, 25 to 30 degrees, because that is the best plane wherein you get a best short axis of the aortic valve, and add 90 degrees to that, so makes it a long axis straight away. And with the 3D probes, now it's orthogonal views, so you just put that and you automatically get, if you want a simultaneous, you can get a long axis and short axis view together as well. And then mid-esophageal 5-chamber view, just to assess what is exactly happening, where the AR jet is going. Deep transgastric long axis and transgastric long axis view, which is for the, if you can't get a deep transgastric long axis and you want to measure the aortic velocities, then it's a transgastric long axis view. And then finally, everything is coming to 3D. I'm sure within 1 or 2 years, Deepak will start talking more about 3D and he'll leave away the diastolic dysfunction. But let's see how it goes on. So, in short, what is aortic sclerosis is just nothing but a thickened calcified cusp with preserved mobility. So, the important aspect is most of the patients above 70 will have all this. There will be slightly increased gradient, it may not be, because it depends on the flexibility of the aortic leaflets, and that's why sclerosis is not a problem. It can happen with many patients. The associated peak Doppler velocity is usually less than 2.5 meters per second. So classification by etiology is, one is classic, then is a rheumatic, classic one, then the congenital is bicuspid, myxomatous surroundings, which is predominantly in Marfan's, and endocarditis. And dissections the commonest reason, or in emergency aortic lesions is the dissection is the important aspect. So this is the one which is the first one, which is a calcific. If you can classically see that how it happens, that there is a dense calcification and there is element of aortic stenosis as well as aortic regurgitation, because what Amish has explained is the leaflet movement restricted in systole as well as diastole, and that's why there are both the elements there. So in a classic aortic stenosis, it is characterized by the rheumatic aortic stenosis. It's characterized by the commissural fusion, the triangular systolic orifice, and thickening and calcification. So it's accompanied usually by a rheumatic mitral valve disease, because that is the commonest valve which is getting affected. And how Amish has said that it's the leaflets which get affected first in the rheumatic mitral disease, and the elderly it's the annulus which is getting affected. But in the aortic valve, it's not exactly the same way, because in elderly it predominantly starts with the calcification of the leaflets. Then there is something called as the subvalvular aortic stenosis, which is important to determine because that can cause AS. It can show as a AS, and there will be associated AR as well with that. So there is a thin discrete membrane which is consisting of a endocardial fold, fibrous tissue. It's a congenital issue. So the patient will be born with the subvalvular aortic stenosis. There is a subaortic membrane over there. So sometimes surgeon will, you will hear SAM. So that's nothing to do with the mitral valve. It is a subaortic membrane. So that's why the short forms are all confusing. So you should be complete with the words. So it's a diffuse tunnel-like narrowing in the LVOT, which is causing the actual obstruction. And how you can determine that? As we normally do the short axis examination, you can actually see the aortic valve is working well. And you go further down inside and you will note that there is another obstruction in the LVOT, and that's why you should be careful in doing those movements when you are assessing the aortic valve. So there is a little bit of a case. So she was a young girl. So if you see at the aortic arterial trace, it is almost resembling like a aortic valve stenosis over here. But the actual thing was something different. So that submitral LVOT lesions, they can mimic the aortic stenosis when the aortic valve is actually normal. But in that case, because of that gradient at that LVOT, the aortic valve will have aortic regurgitation at that point, because there is a lot of turbulence under the leaflets, and there is a possibility that the leaflets get sucked in at that time. So this is a M mode of a normal aortic valve. Why I have placed this picture is just to understand what are the events that occur actually in the routine cardiac cycle. So the aortic box is the opening of the aortic valve, and the straight line represents the closure of the aortic valve. So there is a big difference between the systole and diastole at the aortic valve level, and this is what we take into consideration when we actually do the color Doppler and other examinations. So the Doppler assessment of the aortic valve, which we will see, because the structural part we will see when we are actually looking at the end, we will see the various locations where short axis and long axis. But let's go quickly through the Doppler assessment. So the primary hemodynamic parameters, these are recommended as per all the societies, is the peak transvalvular velocity, mean transvalvular gradient, because that's how you quantify the aortic stenosis, and the area valve by continuity equation. And why that is important, because sometimes you can't get good views, probably for a planimetry thing, probably this is the only way you can quantify the valve area. So the peak transvalvular velocity is 3 or more beats are average in sinus rhythm, but in irregular beats, if somebody has an AF, then you have to at least average out the 5 consecutive beats which you will get, then only you will get a proper peak transvalvular. It is measured by the continuous wave, because there is no point in locating exact position of the aortic valve, which is difficult in a calcific situation as well. So usually it's a continuous wave, and second reason is the velocities are high, so obviously you cannot measure with the pulse wave Doppler. So any deviation from a parallel intercept angle will result in the velocity underestimation. So you try to keep it under less than 20 degrees of deviation, because that gives you the best result. The degree of underestimation, as we all know, will be less than 5% if the angle is within 15 degrees of the parallel. Angle correction on some machines is there, but it may not be it should not be used because it is likely to introduce more error given the unpredicted jet directions in some situations. We tend to use the angle correction if you can easily find a button. So the peak transvolular velocity, why this is important? It is the shape of the continuous wave Doppler is very helpful in determining the aortic valve, the flow through that. So in the severe obstruction, the maximum velocity occurs late in systole and the curve is more rounded in shape. That is something we have to remember that. With the mild obstruction, the peak is in early systole with the triangular shape of the velocity curve. So if you see the picture in the second, if you see that it's the rounded curve is seen when there is the maximum velocity is occurring at the midpoint and not as in the second image where the maximum the peak velocity is occurring in the early systole. So that is bit of a triangular shape of the velocity curve. So even looking at that, especially after replacement of the aortic valve, even looking at the velocity curves, you can say, oh, whether this patient will have a patient-prosthetic mismatch or not, depending on the activation, the early peak systolic velocity of that particular jet. Whatever ways you try to quantify with the numbers, looking at the image also can give you a good quantification, but obviously you need to look from that perspective and not always from the number side of quantification. This is this thing. The shape of continuous wave velocity curve can also be helpful in determining the obstruction is fixed or dynamic. Why that is important? Because this is a dynamic subaortic obstruction, which is a characteristic late peak velocity curve. So the early peak velocity curve was a normal aortic valve, but the late peak velocity curves, that was whatever we were suspecting in a SAM situation, the sub-aortic obstruction. So the concavity of force curve in the early systole is the velocity is high, but the peaking is occurring in the after part. So the possibility of dynamic subaortic obstruction is quite this thing. The another classic example of that is the other SAM, which we were always discussing. So this mitral leaflet comes in between and then it is causing the problem. So this is a classic dagger shaped thing, is the reason why you will get similar curve. But then you have to obviously time it with the ECG at what stage it is exactly happening. So the second one is the mean transvolular gradient, and everybody is aware of the Bernoulli equation, that how it is going to be calculated, and we will not go much into details. So quantification wise, this is the classic table everybody will get: the aortic jet velocity in aortic sclerosis to severe aortic stenosis, the mean gradient, and sometimes the aortic valve area, which you can determine, but sometimes due to a lot of calcification, as in mitral valve, it is difficult to determine exact opening. It can be tricky in aortic valve as well. But try to zoom it, and sometimes you will be able to pick it, run through the clip very slowly and appreciate at what point is the maximum opening you can see, and stop at that point and then take a circular measurement. Then there is something what we call as a velocity ratio. So that is we will come in the next slide. So the aortic valve area by continuity equation is one of the important thing which everybody should understand when you are doing the hemodynamic measurements. So what they assume here is whatever goes through the LVOT has to go through the aortic valve as well. So the LVOT dimensions and the aortic valve dimensions and the velocity is through the blood is passing through these two, they should match, because the same cardiac output is going from the LVOT and it is going through the same narrowed aortic valve orifice, and that's why the area of the aortic valve, which you can get by determining the velocity and the area of the LVOT divided by the velocity at the aortic valve. That is the basic concept behind the continuity equation. So AVA is CSA of LVOT and VTI LVOT divided by LVOT VTI. Let's take away that if you take out this area calculation away from that and make it simple, you can probably sometimes get a dimensionless index also, because measuring the LVOT area, if you can't measure the LVOT correctly, then obviously there is going to be a problem. So with just the velocity comparison can also give you the dimensional index. But before that, we will just go through that how you are going to do the aortic valve area continuity equation. So the VTI is measured by tracing a dense model velocity throughout the cycle. This is for the aortic valve, and for the LVOT obviously you have to put a pulse wave Doppler in the LVOT and measure that LVOT VTI. So these two different VTIs you are getting. For LVOT dimensions, you should always go into the one of the long axis, or if not at all possible, in the deep transgastric view where you can see the LVOT clearly. But the ideal position is a aortic wall long axis where you can get the, because it's exactly at the 90 degrees and you can get a better picture over there. So what are the limitations of this is the observed changes in valve area changes with flow rate, because if the flow rate is low, the distension of the dynamic parts, say LVOT, will not be more, so it can change. AS and normal LV function, the effects of flow rates are minimal, but AS with low LV function, the effects of flow rates are that they affect the measurement of the limitations of this continuity area equation. So what people have come out through that is the velocity ratio to reduce the areas. What we have seen, that velocity ratio is velocity LVOT divided by velocity aortic valve. That gives you some quantification about the stenosis of the valve. So what they are doing exactly over there is they are measuring the LVOT velocity and the aortic valve velocity by two different modalities obviously, and then you get what is called as a dimensionless index, and anything less than 25 is a part of a severe aortic stenosis in that. The one of the important aspect is left ventricular systolic dysfunction. So a low flow, low gradient AS, which includes the following conditions: the effective orifice area is less than 1, orifice area is less than 1, the LV ejection fraction is less than 40%, and the mean pressure gradient is 30 to 40 mm of Hgs. So severe AS with severely reduced LV ejection fraction represents a 5% of AS patients, and you do get such patients. And how to rule out whether that is because of the LV problem or actually the valve is, there is a severe stenosis. So for that we are normally using a Dobutamine stress test. So what it does is, why Dobutamine stress test, it is going to increase the LV contractility. So obviously the flow is going to go up. With the flow, if the defect is fixed, then obviously the gradient will go up, and if the defect is not fixed, if it expands further, the gradient is not going to go up. So that tells you about the problem of a LV which is representing as a severe AS, and that's why Dobutamine stress test is something which is done. I don't know, does anybody does it in Aurangabad? Nobody is doing that. So you better take an initiative and you can start doing that. It's not a, no, because this is why I am saying this, because the BSc people, they always say that there is no harm in doing it. Okay. And the cardiologists are telling, it is not that the anesthetists are saying. So the cardiologists also say what we are worried is something will happen with the patient. The patient has the AS. But world over they have done so many things and nothing has happened. If there is ectopics or some ventricular ectopics or something starts, then probably you can stop at that point. There is nothing to worry about. But you can give a better diagnosis, aortic valve. And if the cardiologist is supportive, I think you can easily do it. Where in Pune, at my place, the cardiologists themselves are doing it, because this is classically needed for TKR patients actually, and not for aortic valve lesions. So the TKR patient, if they are doing it, they can find out if there is aortic valve disease as well. But anyway, the patient is going to come for cardiac surgery, the patient who has AS. But to rule out this true AS, or it's a low flow, low gradient situation, we can do that. And the final thing is a aortic valve planimetry. But as usual, planimetry can be inaccurate because of the calcification and all those problems. So we'll go just quickly through the aortic regurgitation. So about 80% of adults with AS also have some sort of aortic regurgitation, because the leaflets, obviously, sometimes the defect is more, the leaflets just don't co-opt, so there is a AR as well. So the high trans aortic volume flow rate, maximum velocity, mean gradient will be higher in the expected valve area in that situation. Those reporting accurate quantitative data, both stenosis and regurgitation, has to be considered together. The associated mitral valve disease with severe mitral regurgitation, the trans aortic flow rate may be low, resulting in low gradient, which is obvious because most of the LV output will go through the mitral regurgitation and less will come through the aortic valve. So the aortic valve, though it is stenosed, they will be under, the flow will be less, and the valve calculation will remain, area calculations only valve area calculations will remain accurate in that, and that's why the importance of the continuity equation is more in that situation. The high velocity MR jet may be mistaken for the AS jet. How in this the next thing? So there are two jets which we normally see if somebody puts the continuous wave Doppler in the aortic area. It will pick up both the signals. It will pick up the aortic signal. It will pick up the mitral signal as well. But the ECG is going to tell you about what exactly is going to, which signal is which. So something that starts slightly after the R wave is a aortic valve. Though the signal itself is characteristic, it has its own signature. You have a LV OT spectral Doppler followed by a aortic valve spectral Doppler. But if the ECG is not there, and if you see the third picture over there, it starts immediately at the R wave. So that means it's a mitral regurgitation, which is as soon as the LV contractility starts, the regurgitated starts. So that's why you should know that a high velocity MR jet and the normal aortic stenosis jet, they are different related with the ECG. So the effects of concurrent conditions on assessment of severity is left ventricular systolic dysfunction, that's what we have seen. In ventricular hypertrophy, a small ventricular cavity, a small LV ejects a small stroke volume. So even in severe AS, the AS velocity mean gradient may be lower than expected. And if you are doing the TAVI nowadays, this LV is sometimes they call it a suicidal LV as well, because after doing the valve, the cardiologist is pretty careful about it, because there can be sudden death after doing this, such patients as well. One should be aware of this, that the small ventricular cavity is something which is dangerous. Aortic regurgitation, I predominantly look from two perspectives. What is the hemodynamic between acute aortic regurgitation and chronic aortic regurgitation, because two conditions are totally different. Acute AR, which can occur because of conditions like dissections, which can predominantly cause severe AR. So what is the problem with that? There is a sudden increase in the LV ADP, which is going to reduce the stroke volume as usual, because everything depends on the difference between the aortic pressure and the LV pressure. So that is going to increase the regurgitant volume and preload is going to go up. As usual, the heart failure is going to happen much quickly in a case of acute AR, and that's why we have to look at it very seriously and quickly for the survival of the patient. It is something like acute MR which is not tolerated by the LA. The patient will definitely die if you try to conserve a papillary muscle rupture, saying that, oh, we will put a balloon and the patient will survive. The patient will never make it if you keep prolonging it. You have to do the mitral replacement quickly. Similarly, for acute AR also, if you want to do something or dissection, do it as quickly as possible, as early as possible. The chronic AR on the other side, it allows the LV to adapt. It remodels without increasing in the LV ADP, and that's why the person can be beneficial. They can be managed by medical therapy. When you reduce the SVR, automatically the LV output is going to be better and better. So the LV compliances keep changing. LV dilates, it hypertrophies, which we classically call as eccentric hypertrophy. And the systolic dysfunction sets in because of maybe ischemic heart disease or something, then these patients are in more trouble, because they just cannot cope with that now. And that's why the failure occurs. So whether you should operate these patients after a long time, it's again a question, because even after doing aortic valve replacement in those situations, if the myocardium itself has not adequate power, then probably still those patients' heart failure will not be well controlled, because then the diastolic dysfunction will set in, because the LV compliance has gone down by that time. So these are the two aspects why we should look at those two patients. The very chronic AR, which has the LV dimensions has gone beyond 6, probably it is not going to work unless it's a young patient. For elderly, it is going to be a tricky situation. So this is the kind of LV which you will see, a big LV there. So you can see that quite a big LV is there. So obviously that is not going to be a best LV even if you do a aortic replacement over there. And then the classification of the aortic regurgitation, the functional classification, Al-Khoury and people mentioned about that. So it is similar, the normal cusp motion. So it's a root dilatation which is going to happen. the mechanism of all those things. So accordingly they have classified actually type 1 into A, B, C and D. Some of that will be because of the rupture in the leaflet, the hole in the leaflet. Some is root dilatation. So the first part is because of the dissection part, which is causing a problem. Type 2 is a cusp prolapse, which may occur because of normal pathologies, and type 3 is a cusp restriction, which is common with the aortic stenosis, and then cusp restriction, so there will be aortic regurgitation. So what they have tried to do that is a functional classification of AR, and as I explained that type 1 A, B, C, D, what exactly is going to happen, the excessive mobility and the restricted mobility. So in examination what we are going to do is predominantly is the valve tricuspid, then there is evidence of eccentric cooptation. So the valves can be unicuspid, they can be tricuspid, or they can be quadricuspid as well. If you pick up quadricuspid, just keep it with you. If you pick up a unicuspid, also keep that image with you, because they are rare occurrences. So and then you look at the cusp thickening and calcifications, and is any evidence of perforation from vegetation, if you are looking at the aortic valve, this thing. So valve anatomy, then the valve structures, the valve function, the cusps are thick or redundant, sagging in diastole or prolapsing, and the aortic root, dilatation, degeneration and malformations. Let's see if this is working. Yeah, so if you see that, so in this case, which cusp is prolapsing? So if you look at the same thing, again the annulus of the aortic valve, and what is happening with the leaflets, the cooptation point. The same applies, what is applied in mitral regurgitation we apply over here. So in the initial phase you will see it is the right cusp which is going down definitely, but as it progresses, probably you can see the cooptation point itself has shifted a little bit down. The important aspect what I wanted to show is this is the image in 2010. What images Ami showed were in 2020 probably. So see the difference, but still the resolution has changed so much. So to pick up a structural defect is also much simpler and it's more clearer nowadays. It was not bad in those days, but definitely last 10-15 years it has refined so much, and the image rendering is excellent nowadays. So this is about something about morphins. See that the aorta itself is so big, so everything has got stretched up. And then the left ventricle, what sort of concentric hypertrophy, increased LV mass, relative wall thickness, is it higher, more or less? Normally it will be eccentric hypertrophy, and increased LV mass but normal relative wall thickness, is the LV dilated. That suggests the chronicity of AR and increasing the severity. And the LV function is diminished or not, maybe because of various reasons. Let's see. So what do you think here? There is eccentric hypertrophy, but the LV looks good. So definitely there should not be any problem with if you want to replace it. And that is another LV. So what one should do with this? So as a smart person will say, no, you have not showed us the same view, the aortic short axis. So, but anyway, the whole idea was to show how the LV becomes big into these situations. So the evaluation by color Doppler or quantitative, what you see the jet width. So that is what is called as the Penny's index. So mild is less than 25, moderate is 25 to 64, and severe is 65. And there are some images coming with that. So this is the first one. Okay. So that's the AR jet. If you want to do the Penny's index, you have to calculate the LVOT diameter, freeze the image, LVOT diameter and the diameter. Or just put a M mode actually, rather than doing it. Everything comes in together in that. So there must be some measurement down there. So this is slightly bigger, more than 25, less than 64 probably. And then this is a, and if you see there are 2-3 jets as well. There is an eccentric jet going down and something which is going down. And then what we do is, this is the thing. In this also you can determine that. In the short axis also, where is a, you can determine about the jet. You see here the eccentricity of the jet, or you can perceive more over here in between the RCC and the NCC. And then finally, this must be something to do with the Marfans as well. There is a big opening there. And this is what I was talking about, that you put a M mode in that area and you can appreciate that it's definitely, if you look at the dimensions of the LVOT and the regurgitant flow, which is in between the two boxes, so it is much less than 25%. This is slightly bigger than that, but still maybe borderline, and this is definitely bigger than that. So here it is 0.7 and 1.9. So Doppler views, deep transgastric view, transgastric long axis view as we have said. So that's the deep transgastric view, which Deepak had showed in the beginning, and then comes the transgastric long axis. And why they are important? Because at least you can have a your Doppler alignment will be within less than 20 degrees. In this view, obviously there is a problem with less than 20 degrees, but in deep transgastric it will be almost straight. So the chances of getting best aortic velocity is in a deep transgastric, because sometimes to get this view can be tricky as well. And this is the one. So the AR jet, which you can see, the quantification by jet width and the jet area into the LV, people are still doing it, but predominantly we look at the vena contracta and how is the Perry's index. So this is a quantitative evaluation, that PhD, how you measure that. So what you do is you get a trace like this, and you are going to measure the pressure half time or the decay slope or deceleration slope, and the image for this will show you that how that image will change, the spectral Doppler, how will it change, the slope of the decay slope over here and the decay slope over here. You can appreciate that if it is a severe area, how quickly the decay will occur. And then finally you are going into the aorta to look at the hollow systolic flow. So if that is occurring, especially in the towards the abdominal aorta, there is a definite chance that the patient has a severe AR. So this is what you will see over there. And finally, we will have a mechanism of aortic regurgitation in the case of dissection. So what happens is a dilatation of aortic root, annular widening or diseased aortic valve can cause that. So this is one of the type A is the regurgitation that is occurring over there. Then secondly, disturbance of the cusp closure due to hematoma at the annulus, so that is type B over there. And then cusp prolapse due to annular destruction, which is type C. And finally, the prolapsing dissection flap goes through the aortic valve and obviously prevents the closure of the valve, and that can cause problems. So I'm sure this will not play. So in short, that's what about the aortic regurgitation, and thank you for your patient listening.